And that's actually a misunderstanding. Is not how either kind of DSM or ICD understand the issue. That they're not. Diagnosis is not about even about identifying the causes or locating the causes, within the individual. And in fact, I mean, there's broad recognition that the causes of psychiatric problems and psychopathological problems are multifactorial, that they kind of,
Right.
it's not one, you have a range of factors that are interacting. And some of these factors are physiological or kind of genetic or kind of related to brain circuitry. Some of them are best described in psychological terms, defense mechanisms, kind of learning, other personality factors or personality traits.
Dr. Aftab, thank you so much for being here. It's very exciting to me. I'm a big fan. You might be the most famous guest I've ever had. Thank you for coming to What the Fuck is Life. For those who don't know, Dr. Aftab is a psychiatrist. He teaches at Case Western, I believe, and also has a relatively popular, which again, my world is famous, Substack called Psychiatry at the Margins, which is this integrative, inclusive, and correct me where I'm wrong, psychiatry blog, but also with a philosophical tinge or ontological tinge on how to incorporate phenomenological psychiatry and psychotherapy and psychoanalysis stuff. And so you're trying to get it all in. And you wrote this paper about a year ago, I believe, about pluralism in this connotation to do more with psychiatry and diagnosis. But it made the rounds. It made the rounds on the listservs where all of us cool people hang out. And it made a little bit of a splash. Mazel tov to you for that, first of all. So thank you again for being here. And to get started, if you could introduce that paper or what brought you here today, and a little bit of your background, if you'd like. I'm so humble and so happy you're here.
Thank you, Max. It's a pleasure to be here, and looking forward to a fun conversation as well between us. So thank you for kind of pointing out and starting with that paper. So it was paper in a Journal of Nervous and Mental Disease called Psychiatric Diagnosis: A Clinical Guide to Navigating Diagnostic Pluralism. And so I was the first author. Alan Francis was the senior author.
I didn't know that. Right.
Alan Francis would know was the chairman task for DSM-4, and then became a pretty kind of open and fierce critic of DSM-5 as well. And
he has for those who don't know, he has strong opinions. He had an op-ed today in the Times. Did you see that?
Yeah.
Yes.
I saw that.
Yes.
I saw this morning. But this was, I think, this paper, I think, unlike his Twitter account, is much more restrained. And, obviously it was a team effort. There were other co-authors as well.
We all contain multitudes.
Yes. And so the main question we were tackling was that over the years, there has been this shift in scientific circles from categorical models of classification to dimensional models of classification. That instead of understanding mental health problems and psychological distress and impairment in terms of separate boxes, in terms of problems that can be sorted out into different categories, there's this idea that these problems exist on a spectrum, that there are no hard and fast boundaries to these things, that when we look at the population distribution, there's a continuum. These problems exist on a continuum. So how to better address that kind of shift from categorical to dimensional? And this is happening in kind of multiple different ways. It's happening in neuroscientific research, for example, with the research domain criteria, where they're looking at aspects of brain functioning. So they proposed their own research framework called Research Diagnostic Criteria, or RDoC. This was kind of, around 2008, 2009, when that was happening with National Institute of Mental Health. And then around 2016, 2017, from a grassroots consortium of psychologists and psychiatrists who were interested in psychometric evidence, there was a new classification of psychopathology called HITOP, a hierarchical taxonomy of psychopathology, which treats mental health conditions as dimensional in nature. And then if you do statistical analysis and looked at kind of, the quantitative structure, you see that these dimensions form a hierarchy of narrow dimensions such as symptoms, traits at the bottom, and then you have these kind of sub-factors. You have spectra, like internalizing spectra, externalized spectra, and then you have these broad tendencies like the P factor or the general factor of psychopathology. And then, also from the psychodynamic world, there has been this movement towards a kind of psychodynamic diagnostic manual,
Sure.
PDM, and there have been two editions of that. So from a clinical standpoint, clinicians have options now. Previously it used to be DSM or DSM and ICD. They can, for researchers, there's RDoc as a research framework. For clinicians and researchers, there's also HiTop. And for people interested in psychotherapy and psychodynamic ideas, there's a PDM, psychodynamic diagnostic manual. And there are also people who just, who don't believe in diagnosis and who just want to go with some kind of psychiatric formulation or psychological formulation. So there's also that group as well. So we can look at these problems through multiple different frameworks. So how do we handle that? How do we understand the strengths and advantages and disadvantages of these emerging alternatives? And how can these different ways of thinking coexist in clinical practice, psychiatric practice? So that was the fundamental kind of topic or goal that we were addressing in that paper, is kind of critically analyzing the strengths, weakness, and the current status of RDoc, HiTop, psychodynamic diagnostic manual, and some of the anti-diagnostic approaches, and offering some kind of clinical suggestions regarding how they can coexist and how clinicians can navigate between them.
And so you solve the problem.
Well, I think we, in broad strokes, you can say, I guess we offered some, clinical pointers towards kind of how to do that. Yeah, I think some of it involves also, giving up on unhelpful ideas. I think a lot of people have this notion that there exists one objectively correct way of classifying mental health problems or classifying psychopathology. So there's there's the periodic table of elements in chemistry. They think there's one true classification, and we're trying to approximate that. And for a variety of philosophical reasons, that kind of idea of one true classification seems kind of suspect. This is because these are kind of multifaceted, complicated problems that we are dealing with, and they can be looked at and examined from multiple different perspectives. And the best way of classifying them really depends on what we are trying to achieve. So classifications in psychopathology are largely what we might call pragmatic instruments or pragmatic tools, that the best one is going to depend on your interest and your goals. And depending on what they are, one or another framework might be more suitable for you.
Right. So this is as the listeners, as I joke, always have, the few listeners I have, we've had guests on here who, Mark L. Ruffalo certainly comes to mind, that have pretty strong orientations, Mark, I apologize if that's controversial, to their sort of nosological convictions. And they say, it seems that there's a consensus, and of course, deferring to your expertise, correct me where I'm wrong, there seems to be a consensus that at least if it's in virtue, it's in service of the patient. It's in service of public good. It's in service of teaching and training. There seems to always be that undercurrent of, well, the objective classification of disease or disorder or psychopathology, we're doing this so that we can find some common tongue, right? Some common language, some common hand. And yet every time, as you're describing, we have a meeting of the minds, an interdisciplinary meeting of the minds. There, no matter what, irrespective of narcissism, of small differences, is this still pretty strong, this sort of internecine warfare that, in my experience, as can I still be a youngin', it seems harmful. I'm very grateful to say, and as other people or my listeners, which feels so funny to say, have gotten to know me, the more I've learned in these arenas, as I'm a PhD, I'm not an MD, but my interests lie in this neuropsychoanalysis stuff that Soames is really pushing towards. The more you amalgamate it and integrate it, the more humble you become and the more tolerant you are of the interdisciplinary approach, the pluralistic approach. But you don't want to go so far until your brain falls out. That's what always people, I have my own mentors saying that to me in my training. And so my first question for you then is not only your suggestions you made at the end of the paper, but also maybe fast forwarding into what you're working on now. Do you feel that it's more available? Do you feel that people are more well-spirited or good-spirited in saying, no, this is important? Are there people still digging their heels into the biological or medical model? What's your relationship to fighting that fight, dare I say, for a more tolerant or integrative approach?
Yeah. So one thing is actually, so Mark Ruffalo is one of the co-authors on the paper too,
Oh, so
and
who do I know?
yeah, and so and again, I think that
Mark, I'm so sorry.
there are certain points I think on in Mark's his personal views diverge from mine. For example, he's not as, I think, sympathetic to the pragmatic philosophy, for example, as I am towards diagnosis. But I think the paper I think hopefully reflects our shared agreed upon views, and I think the way we understand these. Things. Now, with regards to the current landscape, I think in my day-to-day work as a clinician, when I talk to my colleagues, when I talk to other, for example, and I talk to social workers, I talk to therapists, I talk to psychologists, I think people are generally interested in in more solutions, more options. So
Sure.
I think the idea that, hey, we have multiple different ways of looking at this, at mental health problems or challenges, and they all come with different advantages and disadvantages, and yes, we should use more of them, or depending on the context, their utility will differ. It's pretty unsurprising, even commonsensical, and people take it for granted, and they're eager to learn more about differing approaches. If you look online, that's where I think you see a lot of the, I think, ideological kind of hostility sometimes,
Fire.
and fire, and sometimes rigid views. So it's an interesting kind of resonance between what discussions that take place online, and what most clinicians, I think, experience for various reasons. I think one thing that has happened perhaps over the 10-15 years or so, this was particularly so on Twitter, was that there was a group of psychotherapists and psychologists, etc. A lot of them based in the UK, but not exclusively, who were just very staunchly anti-diagnosis. They just kind of they didn't think that psychiatric diagnosis was a valid, useful, scientifically legitimate, or even clinically legitimate way of thinking about these problems. And so they, through their work, they ended up creating a very strong binary between, you're either on team diagnosis or you're on team formulation or team psychological formulation. And that's what, I find that a very reductive and unhelpful way of thinking about this, because these are obviously, they're not mutually exclusive or even mutually contradictory, and it's not even kind of a rigid binary between the two, because kind of diagnosis oftentimes includes elements of formulation, and formulation often kind of depends on our some kind of categorical schema we're using to understand these things. But I think this group of individuals, many of them associated with the British Psychological Society, BPS, I think were very active online, and I think they created a momentum that around which a lot of online discussions around diagnosis took a more heated approach. And I think what was happening partly was that the discussions were reflecting broader differences in power dynamics that exist between professions. And so we have been working in mental health systems that have often been prioritizing categorical diagnosis to the exclusion of other ways of talking and conceptualizing and thinking about these things. So I think people who find other ways of thinking about psychopathology helpful compared to categorical diagnosis, sometimes they express that dissatisfaction through conceptual debates about disorder, about diagnosis, about DSM, but they're really expressing kind of their anger, resentment, hostility towards
Right.
it.
We call this sublimation as
Yes,
analysts.
exactly. Yeah, sublimation or displacement or kind
Right.
of other forms of depends on how mature you think.
Right. Exactly.
This
Exactly.
is.
In those
So
conferences, there's a lot of immaturity.
yes, yeah. So I think some of it is basically just, I think, using conceptual debates as a proxy for debates that are essentially about distribution of power and distribution of resources. And then I think there's this kind of tendency where I think some factions in mental health tend to see diagnosis as exclusively a medical phenomena. So they think that diagnosis belongs in medicine and belongs in psychiatry, and to diagnose something means to pathologize something, to see it as a dysfunction, to see it as an abnormality within the individual. And they contrast that kind of view with a more psychological kind of understanding of a person's life story. They contrast that with sequelae of traumatic life experiences and adverse life experiences, and they contrast it with other non-medical ways of understanding things like existential or spiritual distress, etc. So some of these, I think, medical versus non-medical dynamics also present as if they are debates about diagnosis, but they're really not technically debates about diagnosis. There are debates about whether we should use the medical lens or medical perspective or not, and if so, to what extent, or what are the limits of the medical perspective. So the debate sometimes gets confusing, and people often get swept up in emotions, and they're less interested in that kind of emotional state. They're less interested in conceptual clarity and more interested in just trying to score points or discredit what they see as opponents.
So for the sake of today's conversation, as unfortunately we don't have infinite time, although I could talk to you about this for a day, there's two things I'd certainly want to hit on. One is the philosophical underpinnings, which are sort of implied to what you're saying, the undergirding as to what gives rise to somebody's conviction about non-diagnosis or non-medical model, as we were speaking to, not just perceptive biases or psychological, even neuroses or limitations, but also maybe more interestingly is where their claim is coming from and what it's founded upon. And then I would hope we still have time to speak to the clinical implications and saying how it behooves us, how it's beneficial, how it benefits the patient, and maybe an example of practically to be pluralistic. Obviously, as maybe my own perspective is I can't see the forest for the trees because I practice every day, and so the utility is right there in front of me when educating myself in whatever parallel discipline or silo has been, in my experience, like you said, mutually inclusive. They fit well and helpful, especially in providing a certain amount of clinical competence or understanding of a case formulation, or even in teaching case formulation to inexperienced therapists of whatever variety. So maybe the first thing I'd like to touch on is, in your experience, as you're so keen on philosophy, is how do you negotiate that? Or is there something that's very clear to you when somebody says, well, this is obviously the pathogenics here are external and to do with societal things, but the pathogenics here, I remember this from my institute training. Mm-hmm. The pathogenics here is completely intrapsychic, and we don't speak to the environmental cause. Mm-hmm. To me, it was always both and. Yeah. Even that is like, my heart's palpitating. I'm anxious to say that. Like, you can't be, like you said, mutually exclusive, both and, greater than the sum of its parts, synergistic, God forbid. And so my question again to you is not only how you negotiate that, but do you speak to the philosophical claims or the perceptive claims or whatever it would be that are generating these
Yeah, we can certainly talk about some of these aspects. So I think one thing you mentioned about internal versus external causation kind of aspect, and I think that often there's a strong kind of tendency among people to think that if you're giving someone a psychiatric diagnosis, then you're locating the causes as being inside the person, and that's actually not
by default.
By default, and that's actually a misunderstanding. That is not how either kind of DSM or ICD understand the issue. That they're not. Diagnosis is not about even about identifying the causes or locating the causes within the individual. And in fact, there's broad recognition that the causes of psychiatric problems and psychopathological problems are multifactorial, that they kind of it's not one. You have a range of factors that are interacting, and some of these factors are physiological or kind of genetic or kind of related to brain circuitry. Some of them are best described in psychological terms, defense mechanisms, kind of learning, for example, kind of like other personality factors or personality traits. This could both be in terms of like the big five personality structure, but it could also be described in psychodynamic terms. And then we have a variety of kind of social political factors. So I think that's a given. The confusion I think somewhat arises because of the way DSM defines mental disorder. So if you look at the definition of mental disorder in the DSM, it has certain components to it. One, it talks about a syndrome that produces a clinically significant disturbance, and that disturbance reflects a biological, psychological, or developmental dysfunction. And that this dysfunction is usually accompanied by kind of distress or impairment in social occupational functioning. So I think critics focus on the dysfunction part. They're saying that the sort of like the problem is caused by a biological or psychological dysfunction. Hence, that means that you are making this a problem, locating the problem as within the individual. Now, there can certainly be a tendency, I think, in clinical settings to do that, but that is not a direct consequence of that definition. What the definition is simply saying is that the focus is on the individual and the problems that individual is experiencing. That is that the goal of the DSM is not to classify social problems or social pathologies. Rather, it is interested in what is happening at the level of the individual. But the problems can arise at the level of the individuals through a wide variety of factors and a wide variety of combinations. So one, I think, is that there's just this element of conceptual confusion. People read that definition and they don't correctly understand what the DSM is trying to say, and they make it about, oh, it's about within the person.
I'm compelled to interrupt you and say that there's the misconception in speaking to the DSM is exclusive since DSM-4, correct me where I'm wrong, as non-etiological, right? Isn't that something that I remember when I was taught, and this was DSM 2013, so 5 TR or whatever it was said non-etiological. And so learning in nosology is different than learning etiology. And so there seems to be, again, back to the kind of philosophical biases we all employ, there's this desire, sort of bottom up, instinctual, what have you, affective desire saying, well, no, if I'm diagnosed with MDD, a very common one, or GAD, general anxiety, very common one, then that means, quote unquote, it's all in my head. Right? It's generated, it's fueled, it's substantiated, it's all given that this is psychogenic and intrapsychic. And again, like you said, it seems to be a very common misconception that diagnosis itself, as I was taught through knowledge, as Gnosticism, doesn't mean anything but an organization of phenomenon through knowledge, a classification of phenomenon through knowledge. But we're very good at binding it or amalgamating it with other stuff to buoy our own, like you said, emotional convictions.
Yeah, so I mean, you're right. I think in DSM-3, so when DSM-3 came out in 1980, it kind of like the language they used at the time was atheoretical with regards to etiology. They basically said that we don't know enough about causes, so if we try to classify these conditions on the basis of causes, they'll just be too speculative and would not be scientifically useful.
It said that in the DSM-3.
That was basically the.
I didn't realize that. Idea. I didn't realize that. Wow.
So Spitzer, who was the chairman task for DSM-3, he used the language. He said atheoretical with regards to etiology, and that's where now some people see that as cynical. Because this was also the time when the clash between the kind of like the biological psychiatry and psychoanalytic group was taking place.
Hell of a time.
And the DSM-3 task force was generally hostile to psychoanalysis. And so one of the ways in which they tried to contain the influence of psychoanalysis and try to purge the presence of psychoanalysis from the manual was by saying, well, we're just not going to go into causes and we're going to remain at the descriptive level. So this was part of it, but I think it was also a genuine scientific assessment. We just didn't know enough about it to confidently say anything. So as a practical strategy, it made sense. What happened though was that even though the manual claimed to be theoretical with regards to etiology, there were still implicit ideas about what kind of problems mental disorders are. The neo-Kraepelinian school was pretty influential in the development of DSM-3, and the neo-Kraepelinian school had the idea that there are discrete mental disorders in the same way as there are infectious diseases and there are discrete neurological disorders. So there are discrete biological dysfunctions that that produce various symptoms of psychopathology, and that the goal of a scientific classification is to progressively find our way towards identifying them. So many in the DSM-3 committee saw DSM-3 as a step towards that. They hoped that the DSM-3 criteria would provide a starting point for the discovery of such discrete entities. So even though it was not based on causes, it was not based on etiologies, there were certain implicit ideas that shaped it, its subsequent reception, and that shaped scientific research over the next kind of 3 to 4 years. And what happened by early 2000s is that basically that assumption was shown to be largely scientifically unsupported. What we know about causes of mental illness, what we know about etiology of mental illness does not point towards discrete etiologies, or does not point towards discrete entities in the mental health realm as they are in, let's say, neurology or infectious diseases, etc. So that's one thing that happened. Another kind of is that DSM and the related ICD, they were both based on, they took clinical observations as a starting point. So they relied on this history of, we have this long history of clinicians working with patients and identifying clinical patterns that they have seen. Clinicians over time identified, there's this schizophrenia cluster of signs, symptoms, and features that it presents in a certain kind of way and has a certain course associated with it. There's a kind of bipolar disorder kind of cluster, generalized anxiety kind of cluster. These were based on clinical impressions that have accumulated over the history of the profession. So they use those. They they presented specific criteria for them. They operationalized them. So the technical term was operationalization, that, for example, for generalized anxiety, you have a list of 6 accompanying symptoms. So you need 3 of them, 3 out of 6, and you need a 6-month duration. So that's basically operationalization, is that you're providing, specific criteria so that different people can agree on it. But it still takes that understanding of generalized anxiety as this pattern that exists. So it's a clinical constructs that are then supported by validators. So they did research. They tried to say, well, what is clinical? What is generalized anxiety associated with? What kind of genetics? What kind of clinical course? And how does that differ from, let's say, major depression, etc. So we had clinical patterns identified, and then there was some partly support from research validators. But there was a group of psychologists that was asking, well, what if we didn't start from clinical observation as a starting point? What if our starting point was something else? What if our starting point was statistical? What if instead, if we had these data sets of psychiatric symptoms and symptoms of psychopathology that have been conducted using rating scales, and we do factor analysis on them, what kind of classification would then emerge from that kind of statistical starting point? And that led the foundation, provided the foundation for the classification I mentioned earlier, HITOP, hierarchical taxonomy of psychopathology, is that it explicitly ignores what's happening in the clinic. It ignores how clinicians have described these patterns, and it says, what does statistics tell us? What kind of patterns emerge from statistical analysis? And the interesting thing that happens when you do that is some of the traditional ways of categorizing disappear. You don't see any major depressive disorder kind of cluster come up. You don't see a generalized anxiety cluster come up. You don't even see a PTSD distinct cluster come up. Rather, because they're all heterogeneous. Is heterogeneous, PTSD is heterogeneous. Other symptoms. So statistically speaking, when you try to identify relatively homogeneous subunits, those things disappear. And what you get instead are these larger organizing tendencies. So, you get the internalizing spectrum, which explains the shared covariance between a wide variety of anxiety and depressive conditions. You get the thought disorder spectrum. You get the externalizing spectrum. And instead of people being assigned a particular box, they get a dimensional profile that every person has a certain location, a certain kind of value, you can say, or a certain score along every dimension. So every person has a certain internalizing score, a certain externalizing score, a certain thought disorder score, a somatoform score, etc. So kind of like how MMPI does, you get a dimensional profile rating on MMPI, get similar kind of thing on high top. And at present, they're using population reference points, T-scores at cutoff. So compared to the population mean, whether you're 1 standard deviation away or 2 standard deviations away or 3 standard deviations away. But they're hoping that in the future, those cutoffs can be informed by clinical research at what point, for example, symptoms become responsive to treatment or things like that. So that's also, I think, another thing is that it matters a great deal whether your classificatory patterns are coming from history of clinical observation or whether your kind of like patterns are coming from statistical research.
Right, which it speaks to, bringing it back to previous conversation and questions, it speaks to your not only philosophy on the matter, but also, of course, which is to say the epistemic claims of this knowledge is more, valid, or it's more testable or falsifiable, and this one maybe isn't. And back to, again, the fight against psychoanalysis 40 years ago. And it's fascinating how over the arc of, the profession, over the arc of diagnosis itself, it's still the same kind of fights, even though we have different approaches or more sophisticated models or ways of gauging it. And yet, I'm just thinking of how I'm not as familiar with high top, and yet what you're saying, inward facing, externally facing. What was another example you said?
The thought disorder.
Thought disorder. Right. Somatoform disorder.
Yeah.
And all I hear is PDM, right?
Yeah.
All I feel is my patient experience. Yeah. And again, but it doesn't scale up in my understanding. It doesn't scale up the same way to, I couldn't certainly paint a diagnostic manual, so to speak, or a diagnostic guidebook, a functional atlas, as I've heard it called, that's never been invented in terms of neurological disease. And it's like the similarities are there, and yet we're coming at it from a different way. And it's almost begging to be said that all of them hold their own value, which I also feel a little self-conscious because it sounds like a cop-out, because I'm like, oh, can we all get along? And it's like, and maybe that's because I'm a shrink in the third born, but like, I don't, it's fascinating to me that you can derive such significance from, I'd love to see the population sets, like you said. I'd love to see how what reports they use to find this cluster is more inward facing, or this was somatoform, thought disorder, et cetera. But to me, it's still back to, cluster A, B, and C, it sounds like, and it's back to, it's so similar.
I think there's a strong kind of, correspondence and congruence in certain ways. One of the main differences is that, so high top is still descriptive. It is still descriptive in the sense that it's remaining at the symptom, at the level of signs and symptoms. It's just kind of, presenting a different kind of organization. It's kind of like, the psychodynamic psychoanalytic perspectives, they go beyond description. They're trying to describe, and they're trying to involve, quote unquote unobservables. So basically what clinicians are hypothesizing about what is happening behind the scenes. So, kind of, for example, ideas about various kinds of unconscious mental conflicts, ideas about kind of how the defense mechanisms are playing out, ideas about other forms of psychological resistance. But I think once you take that into account, to me, if I look at the internalizing spectrum, that looks a lot like neurosis to me. Kind of like, you're looking at it from a different angle. You're describing it in different ways. And I think there are certain there are, I think, groups within psychiatry too, that are, for example, advocating for a return to these broader kind of concepts like neurosis. In reality, things like there's so much comorbidity and overlap between major depression and generalized anxiety and OCD and PTSD that oftentimes an umbrella concept like neurosis can be really helpful and useful compared to partitioning them into subunits that aren't clearly differentiate.
That was Mark's point, right?
Yeah.
In my previous episode, is that it does involve etiology, and of course I want to get to this before the end of today's episode. Is that the etiology and validity of the disease matters, and that if he used the example of ADHD and his strong convictions about it, and I have certainly experienced in my own development as an analyst, my own treatment, psychotherapeutic treatment, but also with patients, is that MDD, as it's called, whatever, a neurotic or borderline level of functioning insofar as a significant morbid or malignant depression, can certainly interrupt somebody's ability for seeking salience and their ability to concentrate, and dopaminergic pathways are amended or reformed or changed by the nature of that constriction or inward-facing weightiness or suppression of affect. And it can masquerade as a attention deficit, or it can result in it, but the cause is quite different depending on, again, I don't have a dog in that fight.
Yeah.
But I'm very interested in how, I guess, back to being my diplomatic self, bear with me, is how you negotiate all that, because it's all reasonable to try to understand at the same time, like you said, the dimensionality of clusters, or moving back to neurosis, to bring it back to what you were going to say before I rudely interrupted, is that it can be so helpful and inclusive. But at the same time, that we do want specificity, given how heterogeneous these things are. And we do want sort of case by case, and we do want people to feel understood. And so that involves a certain amount of tolerance for causality, and also a tolerance for a descriptivist, pluralistic attitude.
Yeah. So I think there are two, I think, aspects that we have to keep in mind when we're talking about classifications and the clinical application too. So there's a utility part of it, which is how helpful are these classifications in making clinical decisions. And in particular, I think for a lot of clinicians, the big thing is, what kind of workup does this problem need? What kind of differential diagnosis should I consider? But also, how do I match this person to the treatments that are available to me? And the treatments can both be psychotherapeutic, and can also be medication-based treatments or brain stimulation treatments. So think of it as the matching problem. How do I match this person's presentation with the wide variety of treatments that are available to us? A practical kind of question. The second element deals more with the empirical aspects of the diagnosis. That has to do with what scientific research tells us about the nature of these problems, or the kind of the interactions of these symptoms. And it may be that what scientific research tells us is just not very useful right now. Maybe it's very complicated, or it doesn't immediately translate into useful treatment approaches. But these are separate things. So, for example, let me explain that in a simple way. Take the question of categorical versus dimensional approaches.
Sure.
In terms of usefulness, we can say, is it more helpful for us to use the categorical classification, or is it more helpful for us to use a dimensional classification that has a continuum as a spectrum, which allows us to better match the person, with the kind of treatments we have available. But we also have an empirical question. The empirical question is that, what does statistics tell us about the latent structure of psychopathology? That's the term that quantitative psychologists use. That what is the latent structure of psychopathology? Now, that is a scientific statistical question. It has little to do with usefulness. It really depends on what the data is telling us. Like if you have kind of like large data sets of psychopathology, it is an empirical question whether that latent structure, understood through statistical techniques like taxometrics. Taxometrics is a branch of statistics that examines distributions of symptoms and tries to identify whether there are any underlying discontinuities within that distribution or no. So discontinuities would point towards a categorical kind of picture. Continuum would obviously be a continuum or a dimension. So a lot of taxometric research has been done of this on this topic. This is partly inspired by Paul Meehl and because he was instrumental in development. But if you look at taxometric research, it overwhelmingly points towards a dimensional kind of model of psychopathology. It tells us that at the population level, at least in groups of people, symptoms of psychopathology, features of psychopathology would exist on a continuum without natural discontinuities, just as personality differences exist on a continuum. So but so we can recognize that. So one person, we could theoretically, for example, say that empirically speaking, the latent structure of a psychopathology is dimensional. But in this particular context, I'm going to use a categorical classification because it's more helpful, right? When it comes to the matching problem, the problem of matching the person with the treatment, it really depends a lot on how research on treatments has been conducted. Like what treatments have been studied under what conditions. And the thing is that right now, the bulk of research that has been done using DSM and ICD kind of frameworks. So if you, for example, want to know, you, for example, have treatments for major depressive disorder, and you have treatments for OCD, and you have treatments for depression augmentation, and you treatments have ADHD, etc. That's how those treatments were studied in clinical trials. That's how they have been kind of understood. That's how prescribing guidelines do it. So if you're trying to match a person with, let's say, you're trying to figure out, is this person going to benefit from an amphetamine stimulant or not, or is this person going to benefit from an antidepressant like Wellbutrin, you have to broadly think in terms of DSM and ICD frameworks to at least try to contextualize how good of a fit there is between what this person is presenting with and the kind of treatments that have been studied. So at least practically speaking, you just don't have the ability to simply give up DSM and ICD right now at the current level of scientific research. Now, 50 years later, if new trials have been conducted using, let's say, psychodynamic diagnostic manual or using HiTop, then sure, things might be different. But again, that speaks to the practical usefulness of what we have. And that usefulness is going to be dependent on context. That's going to be dependent on what treatments we have. That's going to be dependent on other contingencies of history, right? And so I think people often confuse these things, So when we, for example, say that, the scientific case for dimensionality is overwhelming, you'll hear these responses. Let's say, but I don't find dimensional classification very helpful in my practice. I find that categorical more helpful. Sure, maybe they are. Maybe you're right. But the question of helpfulness is also a distinct one from questions of what kind of what the data shows. So it's a similar data. So there's data about there are questions of statistical distribution of taxometric, but then there are also questions of etiological interactions. How do the risk factors that we have identified, how do they interact? What kind of framework makes the most sense? And right now, the framework that's kind of emerging and that seems most promising is the complex systems framework, kind of like the dynamical systems approach. It's a way of thinking about things that have evolved, that we have borrowed from places, analysis of ecosystems and analysis of weather and chaos theory and those kind of things. So we have this new language of talking about dynamical attractors and how these things interact with each other. And in that particular framework, it's not very helpful to talk of isolated causes. The idea that we can talk about environmental and societal causes in isolation, and we can talk about internal physiological or psychodynamic or psychological kind of causes in isolation doesn't make sense, because everything is constantly interacting, layers and layers of feedback loops between the person and environment. So when you have that kind of constantly interacting, iterative, complex system, talking in terms of internal causes, external causes, person, environment just becomes misleading pretty fast. And so I think people in the mental health field still haven't quite caught up with the ramifications of thinking of mental health problems in terms of complex dynamic systems.
It's, yeah, again, and it's so uncanny to be,
Yeah.
I can't help but be diplomatic about.
Yeah.
So if you're interested in this stuff,
Yeah.
dear listeners, complex systems theory very much overlaps with theories of consciousness. And this is my bread and butter in terms of not only global workspace theory and integrated information theory and the homeodynamic principles that give rise to consciousness, but we all have to be tolerant of the difference between an emergent property, like you're speaking to chaos theory, or traffic emerging as a phenomenon greater than the sum of its parts, or they use the perturbations of birds, swallows, and how they communicate in a murmur. There's principles to those systems, and this is again mapped onto or supervened onto how we understand brain function as best as we do right now. It does inform, it's another avenue, I would say, and how we understand not only taxonomy, nosology, etiology, and so on, and that they all are the greater than the sum of its parts. And I have yet to experience an explanation, like you're saying, of siloing these things or treating them in a exclusionary way being beneficial. And the more we're tolerant of even all the statistical analysis versus a more clinically based impression, they seem to inform one another. And I do feel genuinely self-conscious in the sense of, is that such a lame, defanged, almost benign interpretation to make, because it's not spicy enough to say that there's such value, practical value, when I'm face to face with a patient and understanding a side effect profile, from an adjustment profile to the neurophysiological implications to the standard distribution curve in terms of how many weeks of adjustment it could be for this particular medication, supplemented or adjuvant treatment to one another, pharmacotherapy and psychotherapy, or that there's meaning and function that and causal power inside an information inside of a thought, feeling, behavior, conviction, fear, what have you. This is what makes me so interested in your work, is that I'm tooting your horn a lot, bear with me, but it's genuinely fascinating that how are these still fights? How could somebody stand on the soapbox nowadays and say this isn't like a dual aspect monist position, to be super philosophically nerdy? It's both, and it's the mind to supervene on the brain. They're not just, again, I get anxious because it sounds like, is my position just, am I too nice? Is this part of my psychopathology? This is my question.
Yeah, no,
Can you tell me I'm okay?
Yeah, no, you're okay. This is, I think I think you're. I have the same sense of, I think, puzzlement often. I'm like, why are these debates still taking place in the manner in which they're happening?
And they're strong debates.
And they're strong debates, yeah. But even then, and there's also this, I think, this curious disconnect between, again, kind of, what's happening in scientific journals and the kind of the new kind of worldviews that are emerging, versus the kind of these popular debates that you see online on social media, blogs, newspapers, etc. And I think some of it probably just, I think some of it is willful ignorance. I think people stake their positions on certain kind of views in the late 90s, early 2000s, and they just kind of, they budge to, they refuse to budge and refuse to update them. Some of it, I think, is audience capture. I think, simplistic solutions sell.
Sure.
It's hard to explain, this emerging complexity to a lay person,
Yes.
to an average person, right? If you try to explain to them, how to think about the brain and the psyche as a complex system, you need a certain kind of degree of educational background to be able to understand that. You're trying to explain what dimensional systems are, the dimensional kind of approaches are, that requires a certain degree of educational background, versus kind of anyone can go on Instagram, Twitter, and say trauma, and
right, or psychiatry isn't real,
right,
or
psychiatry isn't real, or etc.
yeah.
Any one of these kind of simplistic positions that people take, or or cure everything with exercise, or I mean, whatever simplistic. So
my SSRI, I grew a
yeah.
third arm when I took Lexapro.
Yes. So I think there's an appeal for that. I think we are seeing an increasing, I think, divergence between the kind of the desire for simplicity and the desire for simple answers that many people have, versus the increasingly kind of technical, sophisticated, complex answers that the science is pointing us towards. And then some of it is probably, I think, the social media incentives and audience capture, and and that kind of discussions as well. What I have particularly noticed is that I think late 90s and early 2000s were a particularly harsh period for those people in the mental health profession who were not let's say, biologically reductionistic. I think there was the decade of the brain. I think there was just so much hype around genetic and neuroscientific answers that it traumatized and alienated, I
The
think,
whole generation.
a whole generation of people with that. And so when those answers, obviously, the story turned out to be much more complicated, but
Right, the Human Genome Project was finished in 2003, am I correct? And then that
yeah,
was supposed to answer all the questions once we
right.
had it mapped.
Right, so we didn't
Yeah,
find any simple genes for
right.
mental disorders. We didn't find any simple brain network associations or brain circuit associations. None of the simple answers that people were hoping for from the decade of the brain panned out. And so the people who were on the kind of at that time who were criticized as being, oh, you're just backward and you're not scientific enough, and they have this tremendous sense of resentment. They're like, you were wrong. You promised us in the 90s that we'd had genes
Right.
and brain circuits. And I talked to some people and I feel like they just can't, get out of what things were like in the 90s. They're still fighting the debates of the 90s, instead of recognizing that the scientific landscape has changed entirely.
And that Backstreet Boys were in fact better than NSYNC. That's a hot debate in the circles. Before we wrap up, I do have to ask you, for the sake of practicality, I know you have to run soon. Quickly, either if you're your own as your professor, Case Western, or teaching, or you're doing rounds, or you're working with a patient, is there anything? I do want people to kind of take away with something practical. Is there something you could say that is a little bit easier to digest in terms of staying tolerant of being multivariate, of all these schools of thought, of diagnosis and taxonomy, nosology, etiology? Is there a way that you distill it down? Is there an acronym you use? Is
Yeah.
there something that's sort of pleasant, that you find intuitive?
Yeah, and so I think I gravitate towards this language of perspectives, that we have different perspectives available to us to look at and then understand mental health problems, and that developing a comprehensive formulation of what is happening with this person and what has, quote unquote, gone wrong in some sense, requires looking at it from multiple different vantage points, and each vantage point comes with its own internal logic, and comes with its own advantages and disadvantages. So a useful starting point for me tends to be this book called Perspectives of Psychiatry, written by folks at Johns Hopkins, Paul McHugh and Slavny, and they talk about four kind of clinical perspectives that people can take. There's the disease kind of perspective, which has its internal logic of kind of etiology and pathophysiology and risk factors, etc., etc. There's the dimensional perspective that people can take, which is like, what kind of propensities a person has and how they respond in certain situations. There's the behavioral theory, the behavior perspective that sees in terms of learning theory, reinforcement, punishment. How is it that behaviors get reinforced and acquired over the course of life? So all of that operant learning and Skinner and
Sure.
that kind of stuff. And then there's the narrative life story perspective, which is like, what happened to this person and how did what happened shape them, and shape their development. So there's this kind of developmental life story empathetic perspective. And there's this catchy way of summarizing all this, which is that what the person has, what the person is, what the person does, and what the person encounters. And so, and each of them corresponds to the disease perspective, dimensional perspective, behavioral perspective, and life story. And I say, so I tell the trainees and students and colleagues that we can, any person who presents with mental health problems, we can talk about that and we can look at it and analyze it from these four ways, from these four vantage points. And in many cases, one or more of them is going to be really powerful in explaining and giving us an insight into what is going on. But usually in complex cases, we're multiple of them, maybe even all four of them, to get a proper picture.
And all of them would steer you then towards, just for the listeners, again, if they aren't in the field, towards some form of pharmacotherapy, some form of psychotherapy, and maybe some form of brain electric ECT or TMS or something to that
Yeah.
effect. Now, for the sake of, I apologize for the brevity, those are in general, though, the interventions, so to speak, that are available. That's the other thing. I wish next time we
Yeah.
were meeting, there kind of are, is it okay to say, three categories, in my understanding, that those are it?
The treatment categories.
Yeah,
Yeah,
yeah.
yeah. Broadly speaking, I mean, you have psychotherapy and other forms of psychological
Sure, sure.
treatments. There's
Which
pharmacotherapy,
have
and
many
then
forms, yeah.
yeah, and then there's brain stimulation, and then I guess if you wanted to, you could add a fourth category of lifestyle interventions,
Sure.
things
Okay,
like
so there's four.
exercise, diet,
Right.
etc.
But it's I say that because as we wrap up, there's also less of a mystery in terms of treatment, intervention, tolerance, understanding, all the humility, everything we're speaking to, as if when somebody, like you said, for the sake of desire to be right or desire for a sense of efficacy or omnipotence, whatever it might be, sorry to speak like an analyst, but they want the simple solution, which is only human. And so they say you can solve this complex, emergent, phenomenon within a person that contains this rhizomatic litany of pathophysiology or pathogenesis. And they say, oh, well, all you have to do is sleep better and brush your teeth. If you floss more, there goes your depression. And I'm like, are you fucking serious? And you get the idea. I have to thank you so much, Dr. Aftab, so much for being here. It means the world to me. I'm a new platform, and I've been reading your stuff for a long time. So please, thank you so much.
Of course, yeah, I enjoyed this, and thanks for having me.
Yeah, and next time, if it's okay, I'll invite you on and we'll continue this to see where your research and stuff is going.